Continuing on with Unit 4, Part 4, Objective 48, correlate the effects of pregnancy on the woman with heart disease and discuss the medical management. Due to decreased circulation in the mother, which will lead to decreased circulation to the placenta, this will affect the growth and development of the fetus. And so if a woman has heart disease and has decreased circulation, there's potential that our fetus will not grow and develop properly. The medical management of a woman who has heart disease is to promote cardiac function and adequate circulation and oxygenation to the fetus. We really do encourage the use of epidurals during labor so that she doesn't have the pain associated with labor, which can affect her respiratory effort and such. And then the use of vacuums and forceps extractors during pushings, again, so we don't cause further strain on her heart. Objective 49 says outline the medical management and nursing care of a pregnant client who has pregnancy-induced hypertension. This is in Chapter 14 in your book. Hypertensive disorders contribute significantly to maternal and infant morbidity or mortality worldwide. Maternal complications of hypertensive disorders include placental abruptions, acute respiratory distress syndrome in adults, strokes, cerebral hemorrhages, hepatic failure, renal failure, DIC, which is disseminated intravascular coagulation, and pulmonary edema. Perinatal complications of hypertensive disorders include IUGR, which is intrauterine growth restriction of the infant, prematurity due to preterm labor, hypoxia and acidosis in the fetus, and potential placental abruption. There's classification of hypertensive states during pregnancy, and this is in Table 14.1 on page 335. Gestational hypertension is a blood pressure elevation detected the first time after the 20 weeks gestation without proteinuria. It has been previously known as pregnancy-induced hypertension. Transient hypertension is gestational hypertension with no signs and symptoms of preeclampsia present at the time of birth, and the hypertension resolves by 12 weeks after birth. Preeclampsia is a pregnancy-specific syndrome that usually occurs after 20 weeks gestation and is determined by gestational hypertension plus proteinuria. So now we have an elevated blood pressure plus protein in the urine. And preeclampsia is unique to the human species. There have been no other animals that have been identified that have preeclampsia. Preeclampsia can lead into eclampsia when there's an occurrence of seizures in a woman with preeclampsia that there's no other possible causes for. Chronic hypertension is hypertension that is present and observable before pregnancy or is diagnosed before that 20 weeks of gestation, that midpoint section. And preeclamptic superimposed on chronic hypertension is when a woman has chronic hypertension but now has new proteinuria and exacerbation of that hypertension or proteinuria or thrombocytopenia or increases in hepatocellular enzymes with pregnancy. Lots of definitions there, and it's important to know what is defined as what. Preeclampsia, again, there's the exact cause is unknown. We do know what happens when somebody has it, but actually causing it we don't know. It is again unique to the human species. It occurs after 20 weeks gestation and the patient will have hypertension with associated proteinuria. Risk factors for preeclampsia include nulliparity, family history of it, obesity, multiple fetal gestation, previous preeclampsia, previous poor pregnancy outcomes, several pre-existing medical or genetic considerations of the fetus. These risk factors are in box 14.2 on page 337 in your book. Methods to prevent preeclampsia, this is in box 14.3 on page 337. They include a high protein, low salt diet, nutritional supplementation including protein, the use of antihypertensive drugs, using low-dose aspirin, use of heparin, use of the prenatal care vitamin, and many other things that are listed in box 14.3. So please review that list. Preeclampsia, again defined as increase in blood pressure and protein in the urine. Your nursing assessment includes the blood pressure on the individual. The patient may or may not have edema, but typically they do. We'll need to do deep tendon reflexes, either the patellar ones or the brachial ones. We'll need to assess for clonus, assess for uterine tone, proteinuria, and then ask for signs and symptoms including severe headaches, epigastric pain, right upper abdominal pain, or any visual changes. And if you look at table 14.2 on page 336, you can see the differentiation between mild and severe preeclampsia. In box 14.1, you can see the urine protein values. What's the difference between 0, trace, 1 plus 2 plus 3 plus 4 plus proteinuria? If you look in figure 14.2, you can see the pathophysiology of preeclampsia. Again, the pathophysiology is what actually occurs after the patient becomes preeclamptic. It's what we see. For mild preeclampsia, if the patient is term, get them delivered. The only way to resolve preeclampsia is to remove the placenta, which means we have to deliver the baby. If the patient is preterm, we need to do maternal and fetal surveillance, including blood pressure checks and urine dipsticks for protein, daily fetal kit counts, non-stress tests, or biophysical profiles weekly or biweekly. We'll monitor the baby's growth with ultrasound, and the patient may be on partial or complete bed rest to keep that blood pressure down, because when we walk around, our blood pressure elevates. Severe preeclampsia, if the gestation is greater than 34 weeks, get the patient delivered. If the patient is less than 40 weeks, the physician will discuss the risk of delivering a preterm baby versus continuing the pregnancy. The maternal assessments again include blood pressure, urine output, cerebral status, epigastric pain, abdominal tenderness, signs of labor, signs of abruption, deep tendon reflexes, and clonus. Laboratory tests that are done for somebody who is severely preeclamptic include liver function tests, platelet counts, serum creatinine levels, 24-hour urines for creatinine clearance. Fetal assessments for somebody who is severely preeclamptic include the fetal heart rate, biophysical profiles, ultrasounds for fetal growth, and amniotic fluid index. If somebody is severely preeclamptic, they will probably have hospitalization. And your hospitalization care includes the admission to the hospital. We will do maternal and fetal surveillance for that, including having the patient on the monitor several times a day and assessing mother several times a day as well. They will probably have an indwelling urinary catheter because we want to make sure there's enough perfusion going to the kidneys. They will probably be on magnesium sulfate. Again, magnesium sulfate is a drug not only used for preterm labor, but it's also used for preeclampsia so that we don't go have seizure activity. Normal levels for magnesium in the body is 4 to 7.5 milliequivalents per liter. The antidote for magnesium sulfate is calcium gluconate. You need to have calcium gluconate readily available at the bedside when you are administering magnesium sulfate. Remember that magnesium sulfate is a CNS depressant, so respiratory assessments are important. Anything the patient will have a decreased reflexes associated with the administration of magnesium sulfate. Also with preeclampsia, we may have the administration of other antihypertensive medications. If you look in box 14.6 in your book, there's hospital precautionary measures such as the environment, seizure precautions, call it within reach, emergency medications of hydralazine or magnesium sulfate. If magnesium sulfate is on board, we need to have calcium gluconate available and an emergency birth pack readily available as well. Severe preeclampsia becomes eclampsia when the patient seizes. This is an emergency situation. It is very likely to have fetal distress during and after the seizure activity because mom hasn't had oxygenation during the time of the seizure. The route of delivery is based on the fetal and maternal condition, gestational age, and cervical Bishop score. Just because a patient has a seizure does not mean they need to have a C-section. The physician will decide whether it is appropriate to do a C-section or to try to deliver the baby vaginally. If it is a C-section, regional anesthesia, which is epidurals and spinals, are not recommended if the patient has a coagulopathy issue or platelets that are less than 50,000. Objective 50 says determine the nursing care and management during labor and delivery with a patient with pregnancy-induced hypertension or gestational hypertension, diabetes, and heart disease. Things that we will do as a nurse: monitor maternal vital signs, monitor the fetal heart rate tracings and uterine activity, and notify the physician of any abnormalities. A subdued environment so we don't stimulate the central nervous system and send the patient into seizure activity. A sideline position for patients with pregnancy-induced hypertension or heart disease so we get good circulation to the placenta. Decreased activity for patients with pregnancy-induced hypertension or heart disease so we get adequate oxygenation to the fetus. Monitor the blood sugars in patients with diabetes and report any abnormalities to the physician. Monitor for signs and symptoms of infection and complications, and assess for and respond to critical assessments including an elevated or decreased blood sugars in patients that are diabetic, An elevation in blood pressure is somebody who has pregnancy-induced hypertension or seizure activity, and monitoring for assessing for cardiac decompensation in an individual with heart disease.